Hello everyone. I'm making this video to talk about normal and abnormal labor. Now, I don't know if we have this topic as a theory lecture in our college, but it's a very important topic, so I'll try to make a video about it, and it might be a bit long because it's a long chapter. So, our objectives in this video is list the normal stages of labor, and then describes the complications and the management of these complications. So, what is labor? Labor is a process whereby over time, regular uterine contractions bring about progressive effacement and dilatation of the cervix. Now, we will know what effacement means in a bit, but we know what dilatation of the cervix means, resulting in delivery of the fetus and expulsion of the placenta. And these contractions that happen in labor will occur at least every 5 minutes and lasting 30 minutes. So the physiology, increasing frequency of contractions, we know about this formation of gap junctions. This is unneeded. We have increasing levels of oxytocin and prostaglandins, which and increased levels of specific receptors, which lead to more contractions and induction of the labor. So what are the uterine changes that happen during labor? The contractile upper uterine segment. So this is the uterus, and we look at the upper part. What happens in the upper part? Containing mostly smooth muscle fibers become thinner as labor containing mostly smooth muscle fibers become thicker as labor progresses. So we have smooth muscle fibers here and they become thicker, so they push the baby down. Okay? And what else do we have? Exerting forces that expel the fetus down the birth canal. The lower uterine segment containing, so here, right here, there is many collagen fibers passively thinning out with contractions of the upper segment. So when this smooth muscles contract, the fibers, the collagen fibers here, thin out, so this becomes bigger and the baby goes down. Okay, so we said in labor there's cervical effacement and dilatation. What's cervical effacement? Cervical effacement means cervical softening and thinning. Okay, the thinning occurs because of increasing levels of oxytocin and prostaglandins. So what is cervical effacement? This is the cervix. This is the child and the uterus. So this is during 0% effacement. Okay, there is 0 centimeters dilatation of the cervix. This is the cervix. It's normal. During 30% of effacement, we see the cervix has changed a bit. You see it's big here, it becomes a bit smaller here, okay? But there's still no dilatation. During here, we see it becomes 100% effaced. So what happens? The cervix, you see, as you see here, it's very thin. See? Where does cervix go? There's no cervix, nearly no cervix, okay? Now this is 3 centimeters dilated. This is still 100% effaced. As we see, there's barely any cervix, but it's 10 centimeters dilated. Okay. So occurs as increasing levels of oxytocin and prostaglandins lead to breakage of disulfide linkage of collagen fibers, resulting in increasing water content. It's not important. Effacement is often expressed in percentages with uneffaced, as we saw, 0%. Cervix assumed to be 2 centimeters long and 2 centimeters wide. This during the uneffaced phase. Progressive shortening and thinning lead to full effacement, 100%, in which the cervix has no length and is paper thin. It's very thin. So what about cervical dilatation? Now it's not about the effacement, it's about the gap that we have here. Okay, let's see. This occurs as the passive lower uterine segment is thinned and pulled up by the contractile upper segment. We know where the upper segment is and what it does. In early labor, latent phase. So just before we continue, let's just quickly, we will study the phases more deeply later, but let's just say shortly, the phases of labor, we have stage 1, stage 2, stage 3. So stage 1, cervical dilatation. We have latent phase. It's slow cervical dilatation, which is 0 to 4 centimeters. What occurs here is mild regular contractions that can last for hours, okay? And they are mild, so a bit less pain. But then after the latent phase, during stage 1, during cervical dilatation, we have active phase. So latent phase and then active phase. Active phase is when there is rapid dilatation of the cervix from 4 centimeters to 10 centimeters, which is strong regular contractions and ends with cervix is fully dilated. Okay, that was the first stage, latent phase and active phase. We have stage 2, it's expulsion. It's like we have the cervix dilated, okay? Here the delivery of the baby happens. Mother pushes with contractions, so the mother also tries here, and this stage ends when the baby is born. Okay, so we have cervical dilatation stage. We have stage 2, which is expulsion. Stage 3, after the baby is born, someone else also has to follow, which is the placenta, which from birth of the baby to expulsion of the placenta and membranes lasts about 5 to 30 minutes. Uterus contracts to separate and expel the placenta. Stage 4 sometimes happens, recovery and stuff. So we said cervical dilatation occurs as passive lower uterine segment is thinned and pulled up by the contractile upper segment. In early labor, latent phase, we just talked about that, the rate of dilatation is slow. We said here, from 0 to 4 centimeters, mild, slow cervical dilatation. This is still stage 1, which is cervical dilatation, this stage. The rate of dilatation is slow, but at 6 centimeters of dilatation, the rate accelerates to a maximum rate in the active phase of labor. So, active phase of labor, we just said 4 to 10 centimeters, strong regular contractions, ends with the cervix is fully dilated, 10 centimeters. Complete dilatation is expressed as 10 centimeters. So, we have something very, very important here. Cardinal movements of labor, how the baby, when it comes out, what are the movements that happen. This is in a like a normal pregnancy, in a normal labor. Okay, so the first 3 steps, I just want to say this, and we're gonna check it on a video. Okay, the first 3 steps occur simultaneously and around the same time. This happens: engagement, descent, and flexion. And the next 4 steps occur in order, which is internal rotation, extension, external rotation, and expulsion. We can see like there's a rotation 1, rotation in third point. This is internal, this is external. And then we have an extension and expulsion. Kind of, we can memorize this easily. So I'll not read any of the points. We're just gonna watch a little video on it, okay? So the cardinal movements of labor. This is engagement, the first one right here. This is descent. Baby came down more. This is flexion. Look what happens in flexion. Flexion of the chin to the thorax. And then an internal rotation. Very aggressive. The baby might not be okay here. And then there's an extension, the opposite of flexion, extension, opposite of flexion. And then there's an external rotation. Okay, the baby is spinning around again. Very spinny baby. And then the baby randomly comes out. As we can see, the baby is very happy with the process. So now we're going to talk about the stages of labor. Now we talked about it shortly here in this little note, but now we're going to talk about it in full detail. Okay. So first of all, I just want to know, just want to tell you that here we're gonna try at the end of the video to learn everything in this table. Okay, this is everything that we're gonna learn in this video. Okay, but put in one table. But we cannot just come and explain everything here. Okay, so we're gonna do part by part, like this part, and then maybe this part, and then maybe this part. Okay. So stages of labor here, what's important, just says this one line, a labor curve shows the change in cervical dilatation over time, whatever it says, like all studies is different from new studies. Anyways, transition from latent to active phases at 6 centimeters rather than 4 centimeters. And the note above, it was like, oh, 4 centimeters. Here, no, it says like it's 6 centimeters. Okay. Anyways, so what are the stages of labor? We said there is stage 1, okay, stage 1, and then stage 2, and then stage 3, and then stage 4, which is the mother becomes better and homeostasis or whatever. I don't care about that stage. Stage 1, we said it becomes latent phase, the first one, and then the active phase. Okay, so the latent phase begins onset of regular. So this regular and irregular, I don't know which one it's true because some sources say irregular, some sources say regular. Let's just go with whatever. There's contractions, okay, uterine contractions that are mild. So stage 1, latent phase, ends when there is cervical dilatation to 6 centimeters. Okay, slow cervical dilatation, it ends at 6 centimeters. So this is the function of stage 1 latent phase, is preparing of the cervix for dilatation. Okay, preparing the cervix for dilatation. How long does latent phase last? It lasts under 20 hours in primipara. Okay, they're new to parity, they're new to a baby being born, so they're quite slow. But multipara, now these are professionals, they know what they're doing, so it's less than 14 hours for them in the latent phase. Okay, so if we come to the table, we see how the stages are like this: stage 1, okay, stage 2, and stage 3. Okay, stage 1 latent phase ends right here at 6 centimeters. Okay, what did we study? Preparing the cervix for dilatation. It reaches 6 centimeters at the end of the stage. It takes less than 20 hours in primipara and less than 14 hours in multipara. Okay, so then we go to stage 1, the active phase. Okay, here there is rapid cervical dilatation. So from 6 centimeters to 10 centimeters rapidly. Okay, this is the max. Begins acceleration of cervical dilatation ends at the 10 centimeters, okay, the complete dilatation. So again, the multipara are better than the primipara. Why? The primipara are new to their job. They can do equal or more to zero point 0.7 centimeters in an hour dilatation, but the multipara can do a whole 1 centimeters in an hour. Okay, so let's come here and see. So we ended here in the latent phase in 6 centimeters. We're gonna go from 6 centimeters to 10 centimeters. This is stage 1 active, the rapid cervical dilatation, and we said zero point 0.7 centimeters in primipara and 1 centimeter per hour in multipara. Now we've ended the stage 1, okay? Now we go to stage 2. So stage 2, in some places it says this is expulsion, and here it says the stage 3 expulsion. I don't care about that. What I care about is that we have a stage 2 and we have a stage 3. In stage 2, the baby comes out. In stage 3, the placenta comes out. That's what I care about right now, okay? So stage 2, we ended at like the stage before at 10 centimeters dilatation of the cervix. Stage 2 ends with the delivery of the baby, okay? So descent of the fetus takes less than 3 hours in primipara and less than 2 hours in multipara. So we see multipara are like better than primipara in everything. Okay, add 1 hour if epidural. Epidural here, I'm guessing it means the analgesia, the epidural analgesia. Maybe it makes the contraction slower. Doesn't matter to me. This is what's important right now. Okay, under 3 hours in primipara, under 2 hours in multipara. So we come back to our nice table. Stage 2 descent, okay, descent of the baby, under 3 hours in primipara and under 2 hours in multipara. So we have one stage left, and it's delivery of the placenta, stage 3, okay. It occurs within 30 minutes, okay. So we also have these lines. In stage 1 there is uterine contractions, as we know. Stage 2 there is uterine contraction and there is the mother's effort, okay. And stage 3 there is this oxytocin infusion effort. Maybe you put an oxytocin if the thingy doesn't come out. This is another picture. Look, this is first stage, okay. This is like the latent and active phase. This is the mother's phase. Look at her. And then this is the second stage where the fetus is coming out, and this is the third stage where the placenta is coming out, and this is the fourth stage where there is homeostatic stabilization stage. It begins after the delivery of the placenta and continues for 1 to 4 hours after delivery. Okay, so now we know this part of the table, and this is the same thing. Here is just stage 1, we talked about it. This is still stage 1. This is the latent phase. It says, although the upper limit of latent phase duration may be up to 20 hours in a primipara and 14 hours in a multipara, but if the latent phase doesn't end in these times, it doesn't really instantly go and cut the mother's wound, the mother's stomach, okay? The active phase, the thing is here, cardinal movement of labor occurs, the one we saw in the video, with beginning descent of the fetus in the latter part of this phase. Okay. So, we have abnormalities in labor. Okay, we'll study them all later. Okay, these are the abnormalities. We have an abnormality in latent phase and one in active phase. Here it says the pathology. This the latent phase is the active phase, and this is the stage 2, and this is the stage 3 problem. And we will study them one by one. Okay, so we study the stage 1, the latent phase, and then the active phase, and we said there is here an abnormality. It talks about the active. There's abnormality in all the stages. The latent phase of the first stage has an abnormality which is prolonged latent phase. Okay, that's one abnormality. In the active phase of the first stage, there is arrest of active phase. That's an abnormality. I'll talk about them maybe in a part 2 video or like just later at the end. The rest of the active phase is, so we said active phase, when does it start? When there is 6 centimeters of dilatation, and then there will be quick dilatation until 10 centimeters, right? So it says if we have after 4 hours, okay, of adequate uterine activity, there is uterine activity, and there is 4 hour, we gave it 4 hours, and there is still no dilatation from 6 centimeters, then that's an arrest. Or more than 6 hours of oxytocin administration, yani we gave oxytocin and we see it's still like 6 centimeters. It's not reaching 10 centimeters. That's a problem, okay? We'll probably talk about it longer later. We reach stage 2, okay? Stage 2, what is it? Stage 2 is when the when the fetus comes out, okay, right? It's the stage where the fetus comes out. It's from 10 centimeters dilatation. We ended that in the first stage, and then the fetus comes out at the end of stage 2. So whereas in stage 1, uterine contraction are the only forces. Okay, so we say here there's also maternal pushing effort. That also the mother tries to push. Okay, here's the stage 1, stage 2. Okay, there is mom effort. You see here, right here, there's also the mother's effort. Okay, So stage 2 we talked about is less than 3 hours in primipara and less than 2 hours in multipara. We also add an hour if there is epidural analgesia. So it will be less than 4 hours in primipara and less than 3 hours in multipara if there's epidural analgesia. Okay, so what's left? Stage 3. Let's see what it says in stage 3. Stage 3, we know it's the delivery of the placenta. The mechanism of placental separation from the uterine wall is dependent on myometrial contractions. Obviously, who is contracting? The fat in the area? No, it's the muscles. The myometrial contraction, shearing of the anchoring villi. We know that the placenta has villi like this, right? It's like the villi and it's in the myometrium. So we take this out and it comes out. This is usually augmented with IV oxytocin infusion. We know oxytocin is a hormone that induces contraction, so maybe we give IV oxytocin so we help the placenta comes out, which is here, oxytocin infusion effort. We help the mother, okay? And delivery of placenta happens within 30 minutes. Now I'm talking about this a lot, so we just memorize it like at once, and maybe at the end I will also come back and explain it all again. Uh, Signs of stage 3 include gush of blood vaginally, change of the uterus from long, globular, or lengthening of the umbilical cord. Duration may be up to 30 minutes in all women. Main abnormality is prolonged third stage. So, what's here? Like the abnormalities, the latent phase, we have prolonged latent phase. In the active phase, we have arrest of active phase. It's probably the only different one. In the second stage, we have prolonged second stage. In the third stage, we have prolonged third stage. Okay, so the fourth stage is not an official stage of labor, okay? جاري معاملة تاونك but rather a critical 2 hour period of close observation of the parturient immediately after what's parturient? Parturient here is the explanation. Parturient is a female that's about to give birth, okay? Or gave birth, whatever. Um, Closure of the parturient immediately after delivery. Vital signs and vaginal bleeding are monitored to recognize and promptly treat preeclampsia and postpartum hemorrhage. So we're just monitoring the mother. Now we have this case. It's just a normal case of labor. There's no complications. Just it's talking about a normal case. And what we do with the case, I was gonna explain it in detail, but when you read it, there's barely anything in it. So let's just read the case for some general knowledge. A 20-year-old gravida, so a non-professional, comes to the maternity unit at 39 weeks, nearly term. Gestation complaint it is term. Gestation complaining of regular uterine contractions every 3 minutes for the past 6 hours. Okay, so it's been 6 hours and she's been having regular uterine contractions. The contractions are, I wonder how dilated the cervix is. The cervix is 5 centimeters dilated and 90% effaced. يعني تقريبا it's around this area, right? It's around this area, around the latent active between this area. Okay. It's been 6 hours, so most likely latent. Uh, yes, contracting more frequent. She does any vaginal fluid leaks, so no rupture of membrane yet, normal. There could be rupture of membrane. There's other management for that. Maybe we studied somewhere else. Vital signs are normal. On pelvic examination, the fetus is cephalic. So we have cephalic, we have breech, we have maybe like shoulder presentation. Obviously, the cephalic is a good one. The head is coming first. At -1 station, before we come to this, cephalic, usually what's the like nicest, best way for presentation of the fetus is cephalic, occiput anterior. What's occiput anterior? Occiput of the baby, so the back of his head, anteriorly. So it's anterior, يعني it's the occiput is near the mother's symphysis pubis, let's say, like in the front of her pelvis, you know. So it's cephalic, like this. This is the head of the baby. The baby is looking that way, okay. Um, and this is the baby, like this. This is the head. Okay, the occiput anterior. So this is the occiput, the back of the head of the baby, and it's near the anterior pelvis of the mother. It's a very nice presentation. Anyways, -1 station, we have 0 to -5 to 0 and 0 and +1 to +5. This is just this is the head of the baby in comparison to the ischial spines, okay? So the head is above the ischial spines. This is still descending, so we give it a negative. Our case is like negative till now. 0 is head at the level of the ischial spines, which is engaged, and +1 to +5 has below the spines moving through the birth canal. Okay, what else do we have? It's just other things. Anyway, it says, what do we do with the patient? Pre-admission, the parturient, so we said parturient is female that's about to give birth, is not admitted to the maternity unit until cervical dilatation is at least 4 to 5 centimeters. So we're getting at least until we get close to the active phase. Unless premature membrane rupture has occurred, unless this has occurred, we talked about it first. Fetal presentation is confirmed to be cephalic. This also should be cephalic, and then we do whatever the maternity unit. This is the management is not for us yet, but let's just know it. Admission on admission of intravenous. On admission, there's intravenous access. Okay, we can also give oral clear liquid, but we shouldn't give food in case she needs surgery. The patient is allowed whatever position is comfortable. However, the lateral recumbent position is encouraged, as it optimizes uteroplacental blood flow. The first stage, we talked about the stages. The fetal heart rate is assessed, usually with continuous electronic monitoring. Cervical dilatation and fetal head descents are followed through appropriately spaced vaginal examinations. So, amniotomy, a rupture of the amniotic sac, is performed in the active phase when the fetal head is well applied to the cervix. Obstetric uh, analgesia is administered at patient request. Okay. Second and third stages, maternal pushing. Obviously, we know there's like maternal pushing, the baby will come out. Episiotomy if needed. After delivery of the fetus, the placenta allowed to spontaneously separate, after which IV oxytocin is administered. Let's just highlight this to prevent uterine atony and bleeding. And recovery period is the fourth stage, we can say. For the first 2 hours postpartum, the parturient is observed closely for excessive bleeding and development of preeclampsia. Okay, so in this video, we talked about the stages of labor and the abnormalities in the stages. I'll talk about it in the second part, inshallah. Prolonged latent phase, active arrest active, prolonged second stage, prolonged third stage. We also have some obstetric complications during labor. This is more important to us. Prolapsed umbilical cord, shoulder dystocia, obstetric lacerations, episiotomy. And that's the end of the chapter. I'll hopefully cover these in the next video.